Welcome to this Step 2 clinical knowledge review on prenatal care test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for prenatal care and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the obstetrics and gynecology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for prenatal care on board exams. Second, we will apply specific strategies for questions about routine prenatal visits, screening tests, and high-risk pregnancy management. And third, we will master the next best step question format for prenatal screening, teratogenic exposures, and management of pregnancy complications. This video assumes you have some baseline knowledge from your obstetrics review resources. We are here to sharpen your test-taking approach. Our first strategy is the routine versus high-risk prenatal visit split. When you see a prenatal care question, immediately ask yourself, is this a routine, uncomplicated pregnancy, or is this a high-risk situation? For routine visits, look for normal blood pressure, no proteinuria, appropriate fundal height, and reassuring fetal heart tones. The boards test whether you know the visit schedule, every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, and weekly until delivery. For high-risk scenarios, look for red flags like advanced maternal age, chronic hypertension, gestational diabetes, preeclampsia, or multiple gestations. These patients need escalated monitoring with non-stress tests and biophysical profiles. Make this your first mental framework when approaching prenatal care questions. Strategy 2 focuses on first trimester versus second trimester prenatal screening because the boards test these marker patterns frequently. For first trimester screening, performed between 11 and 14 weeks, you combine nuchal translucency ultrasound with serum beta, human chorionic gonadotropin, and pregnancy-associated plasma protein A. In trisomy 21, beta human chorionic gonadotropin is elevated and pregnancy-associated plasma protein A is decreased. For second trimester screening, the quad screen is performed between 15 and 20 weeks. It includes alpha-fetoprotein, beta human chorionic gonadotropin, estriol, and inhibin A. The classic board pattern for trisomy 21 is low alpha-fetoprotein, high beta human chorionic gonadotropin, low estriol, and high inhibin A. Elevated alpha-fetoprotein alone suggests neural tube defects. Memorize these marker patterns because they are extremely high yield on the exam. Now let us go through high-yield stem recognition for prenatal care. For gestational diabetes screening, the classic stem is a pregnant patient at 24 to 28 weeks presenting for routine screening. Look for the 1-hour glucose challenge test result and know the threshold of 140 milligrams per deciliter. An abnormal screening test requires a confirmatory 3-hour glucose tolerance test. For preeclampsia, look for new onset hypertension after 20 weeks with proteinuria or end organ damage like elevated liver enzymes, low platelets, or visual changes. For teratogenic exposures, the stem will describe a pregnant woman on a medication with known fetal risks. High-yield teratogens include isotretinoin, valproic acid, warfarin, angiotensin-converting enzyme inhibitors, and methotrexate. These question patterns appear repeatedly on the boards. Let us work through our first practice question. A 32-year-old woman at 26 weeks gestation presents for routine prenatal care. She has no significant medical history. A 1-hour glucose challenge test returns a value of 155 milligrams per deciliter. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Remember, focus on whether this is a screening test or a diagnostic test. Let us break this down step by step. Step 1. Spot the pattern. Pregnant woman at 26 weeks, routine visit, 1-hour glucose challenge test result of 155 milligrams per deciliter. This is above the screening threshold of 140, so the screening test is abnormal. Step 2. Apply the rule. The board rule you must memorize is that the 1-hour glucose challenge test is a screening test, not a diagnostic test. An abnormal result requires confirmation with a 3-hour glucose tolerance test. You need 2 or more abnormal values on the 3-hour test to diagnose gestational diabetes. Step 3. Eliminate wrong answers. Starting insulin is premature because you have not confirmed the diagnosis yet. Dietary modifications alone skip the diagnostic step entirely. Repeating the screening test in 4 weeks inappropriately delays the workup. The correct answer is B. Perform a 3-hour glucose tolerance test. Here is our second practice question. A 29-year-old woman at 34 weeks gestation presents with a blood pressure of 152/98, measured on 2 occasions 6 hours apart. She reports a new onset headache and visual changes. Labs show platelets of 90,000 and elevated liver transaminases. The urine protein to creatinine ratio is elevated. What is the most appropriate next step? Think through this carefully. Focus on the severity of the presentation and the gestational age. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This patient has preeclampsia with severe features. The blood pressure is significantly elevated, she has headache and visual changes, thrombocytopenia with platelets below 100,000 and elevated liver enzymes. This is not mild gestational hypertension, and observation or outpatient management would be dangerous. Now, why do magnesium sulfate and delivery win? Magnesium sulfate is the standard of care for seizure prophylaxis in preeclampsia with severe features. At 34 weeks gestation, the fetus is viable, and with severe features present, the risks of continuing the pregnancy outweigh the benefits of further fetal maturation. Antihypertensives alone, like labetalol or nifedipine, without delivery planning are insufficient when severe features are present. The correct answer is C. Administer magnesium sulfate and plan for delivery. Let us review teratogenic medications for the boards, because these come up constantly. For category X teratogens, isotretinoin is the most heavily tested. It causes craniofacial, cardiac, and central nervous system defects. Patients must have 2 negative pregnancy tests before starting and must use 2 forms of contraception. Warfarin is another classic board teratogen. It causes nasal hyperplasia, stippled epiphyses, and central nervous system abnormalities. The key board pearl is to switch warfarin to heparin during pregnancy, since heparin does not cross the placenta. For other high-yield teratogens, valproic acid causes neural tube defects and is replaced with lamotrigine or levetiracetam in pregnant patients. Angiotensin-converting enzyme inhibitors cause renal agenesis and oligohydramnios and must be switched to labetalol or nifedipine. Methotrexate is an abortifacient and causes limb and craniofacial defects. The boards love testing which safe alternatives to recommend when a pregnant patient is on a teratogenic medication. Here is our third practice question. A 25-year-old woman at 8 weeks gestation presents for her first prenatal visit. She has a history of epilepsy and is currently taking valproic acid. She has been seizure-free for 2 years. She asks about the safety of her medication during pregnancy. What is the most appropriate recommendation? This is a classic teratogen management question. Think about the risk to the fetus versus the risk of uncontrolled seizures and what safe alternatives exist. We will walk through the answer next. Let us break down this answer. The classic pattern here is a pregnant woman on valproic acid, which is a known teratogen that causes neural tube defects and developmental delay. She is only 8 weeks along, which means she is in the critical period of organogenesis when the fetus is most vulnerable to teratogenic effects. The fact that she has been seizure-free for 2 years is important because it means she is a good candidate for a medication switch. Now the key distinction. Continuing valproic acid exposes the fetus to known teratogenic risk during the most critical period of development. Stopping all medications abruptly is dangerous because breakthrough seizures in pregnancy can harm both the mother and the fetus. Adding folic acid supplementation while continuing valproic acid does not eliminate the teratogenic risk. The correct answer is B. Switch to lamotrigine after consulting neurology, because lamotrigine has a much safer profile in pregnancy while still providing seizure control. Here is a critical test-taking pearl about the prenatal visit schedule and screening timeline. Prenatal visits follow a specific schedule. Every 4 weeks until 28 weeks, then every 2 weeks until 36 weeks, then weekly until delivery. The first prenatal visit includes a complete blood count, blood type with antibody screen, rubella immunity, hepatitis B surface antigen, syphilis screening, and urine culture. Group B streptococcus screening is performed between 35 and 37 weeks. The anatomy scan ultrasound is performed between 18 and 22 weeks. For Rh-negative mothers, anti-D immune globulin is given at 28 weeks and within 72 hours after delivery if the newborn is Rh positive. The exam frequently tests which screening happens at which gestational age, so commit this timeline to memory. That wraps up our review of prenatal care test-taking strategies for Step 2 clinical knowledge. Remember to review the obstetrics and gynecology chapters in First Aid and your question bank. Focus on prenatal screening timelines, teratogenic medications, preeclampsia management, and gestational diabetes diagnostic workup. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.